Hello, everyone. My name is Fayette Nguyen Truax, and I am an assistant professor from Loma Linda University. I'm also a clinician and a researcher. Today, I have the honor of representing my entire team to present the results of our QI project that we have been working on for the past few years. We are so excited to share the results, and we hope that we can answer any questions you may have or receive some comments at the end of the presentation. So let me share my screen so we can get started. So the title of my study is Latent TB Infection Screening, Testing, and Treatment at a Community Health Center, a Quality Improvement Project. So the names that you see here on this first page are the names of all the individuals who have worked so hard to make this project successful. So the objective of this project is to increase the screening, the testing, and the treatment of LTBI among foreign-born Vietnamese through provider training at a community health center in Orange County, California. So for this slide here, I wanted to show you that just the TB case rates among US born versus non-US born over the years. So for the last several decades, there has been this big gap among the rates between these two groups. And although through the years the gap has slowly is closing, we're still far from where we want to be. And so that's why this type of data is driving our research and our projects to improve LTBI screening, testing, and treatment so that we can reduce the number of TB cases among non-US born persons in the United States. For this slide here, you're looking at the overall TB incidence around the country. And as you can see, the states that are in the peripheral areas of the country have the higher overall average TB incidence. So California is one of them, and we know that California has a very large immigrant population. And so that's why our TB rate is above the national average. So why did we choose Orange County, California? Well, we all know that Orange County is home to one of the largest Vietnamese population in the country. And so that's why it was a perfect place to study Vietnamese immigrants. Second, the TB data has a lot to say. So here I'm showing you the TB stats from 2019, published by the Orange County Healthcare Agency. And I'm just going to point out a few important stats. Although there is a 60% decrease in TB cases from 1993 to 2019 in this county, the overall TB case rates are still higher than what we want. It's at a 5.4 cases per 100,000, and our goal is to get it under 1 if we can. Also, as far as for those with active TB cases, 93% of them are non-US born. And so that's why, again, this population is so important for us to focus on. The most common country of birth among persons with TB in Orange County is Vietnam. 33.5% of individuals who have TB are from Vietnam in this county. And that is significant, and that's what drives our QI project. In Orange County, it is estimated that over 200,000 people have LTBI. And among that, they estimate that about 1 in 6 non-US born persons in Orange County have the LTBI infection. And so that's a very high number, and we need to address that so that we can prevent this specific group from getting TB later in life. Okay, next slide. So treating LTBI infection prevents TB disease, and we know that. And so the purpose of this slide is just a reminder to everyone that it is cost effective to treat LTBI than waiting for the LTBI to convert to TB disease. And so just looking at the cost, it costs between $400 to $600 to treat LTBI infection, as opposed to $18,000 when a person has active TB. If they have comorbidities, they can be very sick and get hospitalized, and the amount can go above and beyond $18,000 for one case. And so that's why if we focus on treating LTBI, um, then we don't have to worry about addressing the TB cases down the road. And it's just a reminder for us to work on projects with LTBI. Next slide. So here I have a picture of just 4 entities that work together on this project. I am from Lowland University, and I initially was working with Dr. Julie Lowe from Orange County Healthcare Agency, Pulmonary Department, on other LTBI studies. And then together we were working on looking for a community clinic. And in our process of doing this, the California Department of Public Health had an announcement that they would assist anyone who's working with LTBI among vulnerable populations. And so we all got together and were able to, everyone got on board to work on this project. My job was to look for a community health center that was willing to participate in this partnership. And I have to say it was difficult. I did send out lots of emails to a lot of different community clinics that serviced a large Vietnamese population, and I only got one email back. And there was a CMO from a community health center that was interested in participating in this project. And so we were very lucky to have them participate. The CMO did ask if we did not include their name in this presentation. However, they were very happy to share, for us to share the results with everyone. So that's why we are very happy to be here today to do that. So the community health center that we worked with in 2018 had over 10,000 patients identified as Asians, with the majority of them born in Vietnam. So we knew that this clinic had a lot of Vietnamese immigrants. Approximately 75% of the patients at this clinic preferred a language other than English, and that was Vietnamese. Okay. So before we wanted to do the training for the providers, we needed to understand a little bit of the baseline data. We wanted to know what was going on and what was the current practice so that we can better understand what we needed to do when we go in to train. And so we asked the CMO and the CEO if we can review some retrospective charts so we can have some baseline data. And so they did give us that permission. And what happened was we did a query of all charts with either a TST or an IGRA test that was ordered in 2017, using the billing data that to retrieve and analyze the information. And so that was our first set of data. Our second set of data, we wanted to look at the physical visits between August 1st to August 14th in 2017 to see if, and to review for LTBI risk factors so that we can determine if the providers perform a TB risk assessment. And so there really was no reason for us to choose August. It was just we needed just 2 weeks worth of data, and we randomly chose that date. So that date is really not significant, but it was important for us to gather this data so we understand what the current practice was before we can go in and improve what they were doing. So what were the results of the baseline data? So in 2017, there were a total of 276 LTBI tests ordered. If we were to break that down, there was only 6 IGRA tests and 270 TST skin tests ordered. Out of these tests, there were 42 positive results, which is about a 15%. And of that, only 3 patients were placed on 6 months of INH, and there was no results documented in any one of those 3 patients' charts that we could find. We really did search. And so that was what we found as far as that data. For the data that we were looking at for this, the subset of charts between August 1st to August 14th, what we found was that there was 124 patients who had a physical during those 2-week period. And out of the 124 patients, 16 patients were tested for LTBI. We didn't know what the reasons were, but 7 had positive results with no treatment completion documented. And so we believe that they were started, but we just never, we didn't find any data that they completed the treatment. And so again, that was very interesting for us. And so it gave us a lot of information on what we needed to do when we went into training. So next, before we actually carried out the training, um, the team wanted to understand a little bit about the providers. We were not sure if the providers may had been influenced by prior experience, or if they were Vietnamese, they had some personal beliefs about LTBI or TB. And so what we did was we borrowed the TB LTBI KAB survey for providers from the California Department of Public Health. They actually used this survey in their other studies, and so we borrowed it to use for this project. And although there were 10 providers, only 8 providers showed up to the training, and so we gave this survey to the 8 providers um, to fill out. So the survey in total had 20 questions, and it was a Likert scale from strongly agree to strongly disagree. So the scale was long. I only pulled out 5 questions to show the group as an example of what the questions were about. Oops, I'm sorry. And so what I want to show is that there were 8 providers, and there were, in general, a majority of the providers actually strongly agree or agree that they had adequate time during their clinic visits to address LTBI, that they thought that LTBI is a priority for them to test, specifically from those who are born in countries with elevated TB. They also said that it was a priority for them to test all patients for LTBI if they were immunocompromised. Majority also said that improving care for LTBI is an important priority for their clinic. And the majority said that they feel that their patients think it is important to be tested and treated for LTBI. And so this data was pretty reassuring for us after we saw this, and we felt pretty good going into this training, knowing that the providers do agree that LTBI testing is important. So the training. Dr. Julie Lowe from the Orange County Healthcare Agency Pulmonary Department was the trainer for this session, and she trained 8 medical providers during this time frame. And the goal was to update clinical practice regarding the screening, the testing, and the treatment of LTBI in foreign-born patients with positive risk factors. What did we do first? So we introduced the adult tuberculosis risk assessment questionnaire to the providers. And we were actually surprised that none of them have ever seen this questionnaire before. Now, at the time that we introduced this, the questionnaire was fairly new, but it was already on the website, but the providers were not aware of it. And so what we did was we were able to make copies and show the providers where to access it, and have them make this as a part of their routine process of screening their patients for latent TBI or TB risk factors. And so we had them give it to their MAs to give to all patients who came in for physicals, and those who they felt were at risk. The second thing that was part of the training was to recommend to the providers to switch from their routine TST test to the new, now recommended IGRA blood test, which is the interferon gamma release assay. And so there was a lot of reluctance and pushback from the providers to switch over to the IGRA blood test, specifically related to the cost and the availability of this test. And so the providers were not sure that their patient's insurance would cover this blood test. And at that time, when we first introduced this, they would have to send their patients to another laboratory that was able to draw the IGRA blood test. So Dr. Lowe and the team worked with the chief medical officer and the biller and other staff members to get the IGRA blood test to be drawn in-house at the community clinic, because they had a lab there where their nurses drew blood every day. And so we were able to get them trained to draw the IGRA blood test. And then we were able to find out from the insurance, the Medi-Cal and Medicare patients, whether or not their insurance covered for the IGRA blood test. And we found out that it did. So that really helped ease the anxiety of a lot of the providers as far as ordering the IGRA blood test to check for latent TB. And so that really helped most of them to switch over to the recommended test. The third point that Dr. Lowe made was the treatment. And so at the time before we came in, the treatment that was recommended for LTBI was the 6 months INH. And so the recommended treatment currently is the 3HP, 3 months treatment for LTBI. And so Dr. Lowe pushed that this is important to do because the shorter the treatment, the better adherence it is. And again, the providers were a little bit hesitant, concerned about the side effects of taking so many pills at one time, and also concerned about whether or not the insurance was going to cover for this drug regimen. And together, Dr. Lowe and the team and the CMO and the staff worked together, and they found out that for the most part, almost all the insurance covered the 3HP if the patients had LTBI. So that was really, really good news for us. So after the training, what were some of the post-training changes at the clinic? So first, they actually adopted the California TB risk assessment as a form that they will use for all of their physicals and for anyone who has LTBI risk factors. So they were using this form routinely. What we found out while we were there was that they were in the process of adopting a new EMR system. And so what we did is we recommended that when they adopt the new EMR system, to implement this assessment form, embed it into this EMR so that it's there and there's no loose papers. And the CMO agreed to do that. And so we were very excited for that change. Second, all patients with at least one risk factor on the assessment forms were recommended to get the IGRA test over the skin test. And we saw that that was being done because we were able to get the IGRA blood test in-house. And we were able to make sure that the fees were something that the patient's insurance was covering. And so overall, that really improved the screening and the testing for LTBI. So then we waited a few months and we wanted to see what was happening about 3 to 4 months post training. And so we came back in about 4 months after the training, and we asked to just survey some random numbers of charts to see what the clinic was doing at that time. And so what we found out was within the 4 months that post-training, the clinic gave out or handed out 285 TB risk assessments during that time frame, compared to none before. And of the 285 risk assessments completed, 279, which is almost 98% of those assessments, were positive for the risk factor of non-U.S. born from a country with elevated TB. So we know that that's the Vietnamese immigrants who came from Vietnam. 199 IGRA tests and only 10 TSTs were ordered during this time frame. So that was very exciting for us because if you remember in 2017, there were only 6 IGRA tests ordered. So now in this 4-month period, we had 199 IGRA tests ordered. So we were very happy with the data that we saw. To continue with the results, so data from the 4 months cohort identified 43 positive IGRA results, of which 28, which is 72% of them, were placed on treatment. Of the 28 patients placed on treatment, 26 were prescribed the short 3HP regimen recommended by public health officials. So we were so happy that they followed the recommendation from Dr. Lowe and put these patients on a 3HP. Only 7 patients completed treatment prescribed, and although that was a lower number than expected, it was still way better than what they were doing the year prior to us coming in. So of note, though, for this period, there was a total of 684 adult physical exams that were done in this 4-month period. And we saw that 256 of them complete the TB risk assessment compared to no TB risk assessment in 2017. And again, these are little steps, but it's a step forward to the right direction. So we were eager to find out whether or not the changes were going to be sustainable over time. And so we wanted to do a 9 months post-training data collection. However, around that time that we wanted to come back, there was a lot going on at the clinic, and they asked us to push back our charts review a few more months because they had a lot of audits that was going on. And so we did not quite um, uh, get to come back as often as we wanted. When we did come back, we were only, it was only 1 or 2, I believe it was 1 day that we were able to look at 46 charts that day of just random charts that were seen for physicals. And so our intention was to review more charts, to come back more days, but then we were told that we couldn't come back due to a COVID. And so that made sense for us because around the time of COVID, the clinic had to shut down and become a COVID testing site. And so we were not allowed to come back to retrieve any more charts. And so it was difficult for us to get we weren't able to get a bigger picture of what was going on. But of the 46 charts that we were able to review, what we found was that only 15 were given TB risk assessments. So of the 46 charts that had physicals in the time frame that we were looking at, only 15 had TB risk assessments, which were all positive. So from there, there were 14 IGRA tests and 1 TST ordered. So that was also good news. They were ordering IGRA over TST. And among the IGRA blood test results, there were 6 negative and there were 8 lost to follow-up. And so that was a little distressing for us that there was lost to follow and no one followed up with the results. But there's room for improvement. So we wanted to work with them on that. And the only 1 TST that was ordered was positive. Unfortunately, that only positive TST, we found in the chart that there was no follow-up IGRA test ordered, there was no chest x-ray ordered, and there was no treatment ordered for that one individual. So, challenges encountered. Although this project was very meaningful and we felt very encouraged and excited about what we've done, we can't escape the fact that there were a lot of challenges that occurred during the project's implementation. The first was, of course, the shortage of their IT staff. Because they had a shortage of IT staff, we were not able to have the IT people run us all these reports that we wanted. And so we were limited in what we can get, especially when we came back to try to look at more data. We did not have the support from the IT to give us those numbers. Second, the clinic was going through 3 audits within a 3-month time frame, so they were very stressed, and they did ask us not to come back during that time frame. So that's why that was a little bit harder for us, and that's why it pushed us back even further into 2020 when COVID started hitting the country. So we said lack of CEO support because, again, the CEO was very concerned about the audits and there's a shortage of staff. And so that was what led to us not being able to get the data that we needed. There was a lack of motivation of providers. The providers were stretched very thin. They did not hire new people. There were people that were rotating out or leaving for new jobs. And so there are providers, the 8 providers, there were 10, but I believe the numbers went down to 8 and to 7. And so because of the lower number of providers, it made it hard for these providers to remember to continue to screen for LTBI and to treat and to follow up. There was also a lack of consistency in TB champion. We did work with the CMO, the chief medical officer, who was also a provider, and he was our TB champion throughout the whole project. But towards the end, he again was strained with time, and he was also transitioning out of his role and leaving the community clinic for another job. And so we asked him to pick another TB champion that will carry on the work that he has done. And that was where we left off with them last. And we talked about the COVID-19 shutdown that interfered with us coming back to finish the data collection. And then lastly, again, the internal staff changes. The providers, some were leaving, there were new ones, and then there's also a change in the CMO. So all of these were challenges for us to implement and maintain the changes that we had put in place. So in conclusion, this QI project led to the development of a successful partnership between the California Department of Public Health, the Orange County Public Health Department, and the community clinic involved to improve the screening, the testing, and the treatment for LTBI in a high-risk Vietnamese population. We were very excited for the opportunity to do this study or project. We would definitely welcome any comments, any questions that you may have. We know that this is a virtual conference, so I believe Evelyn will direct those questions and comments to us. And to just make sure you include an email if you want us to reply to you, okay? Thank you everyone for your time and your attention to this presentation. And we hope and pray you guys have a great conference experience. Thank you so much.